Welcome to the deep dive, where we take highly structured, often complex bodies of knowledge and give you the absolute essential insights.
Today, we're doing a detailed, high-yield analysis of a procedure that really changed everything. Breast conservation surgery, or BCS.
And the material for this is drawn from comprehensive medical review sources, so this is the kind of precise, rule-driven knowledge you'd need in surgical oncology.
Absolutely. The level of detail is critical because BCS, is probably the biggest success story in quality of life care for breast cancer patients.
So our mission today is pretty clear. We're going to synthesize the definitive criteria, the operative roadmap, and the mandatory follow-up that defines this treatment. We're not just summarizing, we're dissecting the why behind all these rules.
And that why is so important. You have to understand that BCS fundamentally changed the entire conversation around breast cancer. It shifted the focus from maximal removal to effective targeted therapy.
Offering the same survival outcomes as mastectomy, but preserving the breast.
Exactly. But to understand its success, you have to understand its components, which are incredibly strict.
Okay, let's unpack this. Let's start with the bedrock. What exactly is the formal, codified definition of breast conservation surgery?
Right. So if you're ever asked to define BCS, you cannot just say lumpectomy.
It's just one piece of it.
It's just one piece. The formal definition, and honestly, every single word here is critical, is this. Surgical removal of the breast tumor with a rim of normal tissue, combined with axillary staging, followed by mandatory postoperative radiotherapy, all while preserving the remaining breast.
That's a remarkably precise statement. It's not a surgery. It sounds more like an entire therapeutic regimen.
It is. It's a regimen. And those three pillars you just heard are completely non-negotiable. It's why we often use the term breast-conserving therapy, or BCT, interchangeably.
Okay, so let's break down those three pillars. The first one is the surgical core.
That's the wide local excision, or WLE. This is the act of removing the tumor, but the key word is wide. We have to take a circumferential margin of healthy, normal tissue along with the mass.
Some people call that a lumpectomy, right?
Yes, lumpectomy, partial mastectomy, WLE. They all describe that first surgical step.
So that handles the local disease, but cancer is a systemic concern, which I guess brings us to the second pillar.
Exactly. The second pillar is axillary staging. No breast cancer surgery is complete without assessing the regional lymph nodes, usually in the armpit.
And that's to see if it has spread.
It dictates the prognosis, it tells you about the risk, and it gives you crucial information for planning any systemic body-wide treatments later on.
Okay, now for the third pillar. You stress this is the most critical one. The mandatory postoperative radiotherapy. Why is that the litmus test for whether this is truly BCS?
This is the absolute golden point. It's the single feature that distinguishes a successful conservation from, well, an incomplete surgery.
How's it?
Look, when you do a wide local excision, even if you get perfectly clean negative margins, you are leaving the vast majority of the breast tissue behind.
Of course, that's the point.
Right.
Yeah.
But that remaining tissue has a microscopic risk of recurrence. The whole purpose of the radiation is to sterilize that remaining breast parenchyma. It cleans up anything that might be left.
So if a patient has a perfect lumpectomy, perfect axillary staging, but then they can't have radiation or they refuse it, the whole model falls apart.
For statistics change dramatically. Precisely. The landmark trials that proved BCS offered survival equivalent to mastectomy, like the famous NSABP B06 trial. They only showed that equivalence when radiation was added.
I see.
If you skip the radiation, the local recurrence rates, they just shoot up, sometimes 3- or 4-fold.
Yeah.
And that can compromise long-term survival. So clinically, if you omit radiation, the procedure just fails the definition of breast-conserving therapy.
It's no longer a complete therapy. It's more like just a debulking operation, and you're leaving the patient at a higher risk.
You've just increased their risk unnecessarily. That's why any trainee asked about BCS has to state that 3-step sequence. It's fundamental.
Okay, so just to nail down the jargon, we hear BCT, BCS, wide local excision, lumpectomy. It sounds like WLE and lumpectomy describe the surgical act.
Right.
While BCS and BCT describe the overall treatment strategy, which has to include the radiation.
That is the clearest way to think about it, yes.
Yeah.
When the surgeon talks about BCS, they are committing the patient to that entire combined approach.
So understanding that definition naturally leads us to the big question of patient selection. This is the filter. Who actually qualifies for this very specialized therapy?
And that selection is paramount. I mean, choosing the right patient for BCS is arguably just as important as how well you do the surgery itself.
So what are the factors?
We rely on a structured set of them.
Yeah.
Tumor factors, patient factors, and the biological profile of the disease.
Let's start with the tumor itself. What size and spatial requirements make a cancer suitable for this?
So BCS is fundamentally designed for early breast cancer. We're talking stage 1 and, non-advanced stage 2 disease.
Okay.
Historically, the source material gives a size criterion, generally a tumor size less than or equal to about 3 to 4 centimeters.
But you mentioned the size limit is relative, which feels a bit odd in oncology, where a millimeter can make all the difference. And why the flexibility there?
That flexibility is just the practical reality of surgical oncology, and it brings in this key concept, the tumor-to-breast ratio.
Ah.
Think about it. Imagine a 3.5 centimeter tumor in a patient with a very large, voluminous breast. Removing that tumor plus the required 1 centimeter margin, you're still leaving a huge amount of tissue. The cosmetic defect is tiny, easily managed.
Right. But the same tumor in a smaller breast.
Exactly. A 2.5 centimeter tumor in a woman with a small A-cup breast might mean removing so much of the gland that the breast ends up severely distorted, asymmetric, cosmetically unacceptable.
So you defeat the purpose of conserving it in the first place.
You've completely defeated the purpose. In those cases, a mastectomy with immediate reconstruction might actually give a better cosmetic outcome. So it's the ratio, not just a raw number, that guides the decision.
That makes perfect sense. And we also need a unifocal lesion, is that right?
Yes.
Yeah.
For safety, BCS is ideally for a single focus of disease. The standard indication is a unifocal lesion to make sure you can get complete clearance and you're not accidentally leaving another malignant spot behind.
Okay, let's move on to the patient factors. What are the key elements of patient readiness?
Well, first and foremost is the patient's informed desire to conserve the breast. We have to present all the data, the equivalent survival, the different risks. The patient has to agree to the trade-offs, especially the mandatory radiation.
And medically?
Medically, they need a good performance status to get through the whole thing, surgery, recovery, and then 5 or 6 weeks of daily radiation. And critically, they must be able to undergo radiotherapy. Anything that rules out safe radiation automatically rules out BCS.
Let's clarify a point that I think can be confusing, the biological and age factors. The sources say that pursue status, it doesn't actually determine if a patient can have BCS. That feels counterintuitive.
It's a really important conceptual distinction. The biology, whether the tumor is hormone sensitive or aggressive or has a specific target, that's absolutely critical for figuring out the adjuvant systemic therapy.
So the drugs you give afterwards.
Exactly. What drugs we give after surgery and radiation. It does not determine whether the tumor can be physically removed with clear margins. As long as the physical requirements are met, size, one focus, ability to radiate, the specific type of cancer doesn't matter for the surgical decision.
And just to confirm, age is not a contraindication either.
Correct. Age alone is not a contraindication. An older patient can have DCS just as safely as a younger one.
Okay, what about location? I'd always assumed that a tumor right behind the nipple, a retroareolar tumor, would automatically mean a mastectomy.
That's a common thought, but it's not necessarily true in modern practice. The location itself doesn't automatically rule out BCS.
Even right in the center?
Even retroareolar tumors. Yes, they pose a challenge, because you might have to remove the nipple areolar complex to get clear margins. But this is where oncoplastic techniques come in. We can remove the nipple and then reconstruct a cosmetically acceptable mound later on, so location is no longer an automatic no.
Which brings us to the no list, the deal breakers. If a patient has one of these, conservation is off the table and it has to be a mastectomy.
Yes. These are the absolute contraindications because they just fundamentally undermine your ability to clear the disease safely.
So what's number one?
The first major deal breaker is this spatial distribution. Multifocal or multicentric disease.
Meaning tumors in different parts of the breast.
2 or more distinct, separate tumors in different quadrants. Trying to cut them all out with good margins would mean removing so much tissue, you'd either cause a huge deformity, or more likely, you'd still leave microscopic disease behind. Mastectomy is the only safe option there.
And the second one is related to that, but for non-invasive disease. Diffuse malignant microcalcifications.
Right. This often signals widespread DCIS. If you see calcification scattered all over the breast on the mammogram, it means the cancer cells are distributed too broadly to be captured by a single clean excision.
You can't just chase them all.
You can't. You might clear one area but leave significant disease somewhere else. It's an absolute contraindication.
Okay, the third deal breaker sounds like a technical failure. Positive margins after a re-excision.
Yes. So, if the initial surgery shows tumor cells right on the inked edge, You have to go back for a second surgery to try and clear it.
A re-excision.
A re-excision. And if even after that second attempt, the margins are still positive, it tells you the disease is bigger than you thought. You just can't contain it with a segmental excision. At that point, you have to move to mastectomy for safety.
And the final absolute contraindication brings us full circle, right back to the definition.
The inability to give radiotherapy.
What are the main reasons someone couldn't have radiation?
The most common one is if they've had prior radiation to the chest wall, maybe for Hodgkin's lymphoma years ago. You can't safely deliver that full dose of 50 gray again without risking severe damage to the lungs or heart.
And the other big one is pregnancy.
Yes, pregnancy. Radiation is highly toxic to a fetus. So if a patient is in her first or second trimester and needs treatment right away, BCS is prohibited because you can't delay the mandatory radiation. They would need an upfront mastectomy, which can be done safely during pregnancy.
And what about inflammatory breast cancer? Why is that always excluded?
Inflammatory breast cancer is defined by the involvement of the skin lymphatics. That signals diffuse, microscopic disease throughout the entire breast and skin. It's biologically widespread from the start. Conservation is just impossible. The rule is firm. Inflammatory carcinoma means no BCS.
Okay, and quickly, what about relative contraindications, the ones that are tricky but not an absolute no?
The classic one is a large tumor in a small breast.
Yeah.
It's relative because, as we said, modern oncoplastic techniques can often solve that problem.
Right.
Another important one is certain collagen vascular disorders, like SLE or scleroderma. The mandatory radiation can cause a really exaggerated toxic reaction in these patients. It's often avoided, but not strictly forbidden if the risk is deemed acceptable.
But the core message is clear. If that safety net of radiotherapy isn't there, the whole conservation strategy just falls apart.
Exactly. The integrity of the concept hinges completely on that final step.
So we figured out who is eligible. Let's trace the journey from the diagnosis to the operating room. That pre-op phase seems crucial for creating a tailored surgical plan.
Oh, it's absolutely critical. And the standard of care is what we call the triple assessment. You need clinical, radiological, and pathological confirmation before any treatment decision is made.
Okay, what does that involve?
It starts with a clinical exam. The surgeon assesses the size and feel of the lesion and critically checks the lymph nodes in the axilla. Then comes the imaging.
Mammogram and ultrasound.
Both. A mammogram is essential for looking at microcalcifications, and an ultrasound is better for defining solid masses and guiding the biopsy. And third, the definitive diagnosis comes from a core needle biopsy.
And that gives you the histology and all the biological markers, the ER, PR, HER2.
You got it. Without that pathology, no surgical plan can be initiated.
Now, for a lot of these early cancers, the lesion isn't something you can feel. How do you make sure you're operating in exactly the right spot?
That's where localization comes in. For these non-palpable lesions, we rely on radiology to place a marker. The most common way is needle localization, where a very fine wire is placed directly into the tumor, acting as a beacon for the surgeon.
Like a little roadmap.
Exactly. It guides you right to the spot.
Okay, now for the surgery itself, let's walk through the steps of the wide local excision. How do you ensure you get that essential clean rim of tissue?
It's all about a meticulous approach. Step one is incision planning. You want to choose an incision that's either radial, like the spokes of a wheel, or curvilinear, following the natural skin folds.
To make the scar less noticeable.
The goal is always to maximize the cosmetic appearance while still getting great access. Then comes step two, the dissection and excision.
So you're cutting out the tumor. How do you make sure you get enough tissue around it?
It's a sharp dissection, and you're isolating the mass with that critical layer of healthy tissue all around it. Importantly, you have to carry the dissection all the way down to the fascia covering the chest muscle to get a clean, deep margin.
And what about the biopsy tract?
You have to remove the track left by the core needle biopsy as well, because there's a theoretical risk of it containing some tumor cells.
Okay, step three. The specimen is out. How do you handle it to make sure the pathologist can give you useful information?
This step is mandatory. You have to place orientation markers. These are usually sutures, maybe a long suture for superior and a short suture for medial. This tells the pathologist exactly which edge of the tissue corresponds to which part of the breast.
So they can report exactly where a margin might be close or positive.
Precisely. After marking, it goes straight to the lab for margin assessment.
And does the surgeon have to wait days for that report?
Ideally, no. We try to get an immediate check. The specimen is painted with ink, and a pathologist can do a frozen section analysis, a rabbit technique, to check suspicious margins while the patient is still on the table.
What about this idea of no tumor on ink? How close is too close?
Well, this has been a huge point of debate. Historically, we aimed for 2 millimeters or more, but based on large consensus guidelines, the standard for invasive cancer is now literally no tumor on ink.
So as long as the cancer cells aren't touching the edge, you're good.
Exactly. For DCIS, we still prefer a slightly wider margin, often 2 millimeters. But for invasive disease, the confidence we have in the follow-up radiotherapy allows us to accept that no tumor on ink standard.
This technical challenge, getting clear margins while also leaving a good cosmetic result, that's where oncoplastic surgery has made a huge difference.
It has revolutionized the field. Oncoplastic surgery is basically the marriage of surgical oncology and plastic surgery.
What's the goal?
The goal is to allow for the removal of much larger volumes of tissue than a traditional lumpectomy would permit, while still achieving a breast shape that's acceptable, or sometimes even better than before.
How does that work?
We use two main approaches. One is volume displacement. This involves mobilizing the remaining healthy breast tissue and fat into the defect left by the tumor.
So you're rearranging what's already there.
You're rearranging, we can use glandular flaps, or for larger tumors, we might use a therapeutic reduction mammoplasty. We essentially reshape and lift the entire breast after the tumor is removed.
And that's what expands the eligibility for BCS. It neutralizes that large tumor, small breast relative contraindication.
Precisely. A 4-centimeter tumor might have been an automatic no for BCS 20 years ago. Now we can take it out with a wide margin, then do a reduction pattern, and the patient ends up with both a safe cancer operation and a superior cosmetic result.
Okay, so that brings us to the final surgical steps, dealing with the lymph nodes.
Step 6 is axillary staging. And the standard procedure now for any patient whose nodes feel normal on exam is the sentinel lymph node biopsy, or SLNB.
And that's the minimal approach.
It's a minimal procedure. We inject a tracer to find just the first 1 to 3 lymph nodes that drain the tumor site. We only remove those.
And the huge benefit there is avoiding lymphedema.
A massive benefit. It drastically reduces the risk of chronic arm swelling, which can be a debilitating long-term problem.
So when do you have to escalate to the full axillary lymph node dissection, the ALND?
We only do a full ALND when we know there's a significant amount of disease in the nodes. So if the nodes are clinically positive before surgery, or if the sentinel node biopsy comes back with more than 2 positive nodes,
Okay.
in those cases, the risk of leaving disease behind in the axilla is too high, so a full clearance is necessary.
So we've gone through the whole procedure. Now the big question, why go through all this complexity? What are the proven outcomes?
Well, the foundational achievement of BCS is its survival equivalence to mastectomy. This is the bedrock of modern breast oncology.
The same chance of a cure.
The same chance of a cure, but with vastly superior cosmetic and psychological outcomes. For many patients, that is an immense life-changing benefit.
But that had to be proven, right? It wasn't just assumed.
Oh, it had to be proven in massive, decades-long trials. The single most crucial one was the NSABP B06 trial. It truly revolutionized care.
What did it show?
It randomized women into 3 groups.
Mm-hmm.
Mastectomy, lumpectomy alone, and lumpectomy, followed by mandatory radiation. And the results were monumental.
What did they find?
They showed, conclusively, that lumpectomy plus radiation gave the exact same long-term survival as mastectomy. And, just as importantly, the group that got lumpectomy alone had way higher local recurrence rates.
Proving that radiation is absolutely indispensable.
Indispensable. That one finding changed global surgical practice. If you're studying for an exam, you have to know this sentence. BCS plus RT has survival equal to mastectomy, proven by NSABP B06.
Okay, but every procedure has risks. What are the common complications with this therapy?
They fall into early and late complications. Early on, you can see things like a seroma, which is fluid buildup, a hematoma, or a wound infection. These are usually manageable.
And the late complications, the ones that are more specific to this approach.
Right. Those require more ongoing management. You can have cosmesis issues, scarring, breast hardening, asymmetry. Something called fat necrosis can also happen, where fat cells die after radiation and form hard lumps.
That sounds like it could be mistaken for a recurrence.
It can be very challenging clinically, yes.
Yeah.
It often requires more imaging or even a biopsy to be sure. And of course, radiation fibrosis, which is a permanent hardening of the tissue, and lymphedema. But again, that's really only a risk if a full ALND was needed.
Let's focus a bit more on that mandatory radiotherapy. We know its purpose, but what's the actual protocol?
So the goal of whole breast radiotherapy, or WBRT, is to sterilize that remaining breast tissue. The standard protocol is usually about 50 gray, delivered over 25 daily sessions for 5 weeks.
And what about the boost? I've heard that term. When is that added?
A boost dose is an extra concentrated dose of radiation delivered specifically to the tumor bed, the cavity where the tumor used to be.
Why do you need that if the margins were clean?
It's for high-risk groups, patients who have a higher chance of local recurrence. This usually means younger patients, say under 50, or patients who had close margins, even if they were technically negative. You're just giving an extra shot of energy to the highest risk area.
The neat pearl here seems to be that without this RT, the whole thing is just not oncologically sound.
It's not. No RT means the recurrence risk shoots up, and BCS is no longer an allowed strategy. It's the core rule.
So surgery and radiation are the local treatments. Then you have systemic therapy, which is the insurance policy for the rest of the body.
Exactly. And this is where that initial core biopsy, with all the biological markers, becomes the roadmap.
So let's start with hormone-sensitive tumors, ERPR positive.
For those patients, the standard is 5 to 10 years of hormone therapy. These drugs either block estrogen receptors or lower the amount of estrogen in the body, basically starving any potential cancer cells.
And it's different for pre- and postmenopausal women, right?
Yes. For premenopausal women, the standard drug is tamoxifen, which blocks the estrogen receptor on the cancer cell. For postmenopausal women, we typically use aromatase inhibitors.
And they work differently.
They work by stopping the production of estrogen in peripheral tissues, which dramatically lowers the total amount of estrogen in the body. It's extremely effective.
Okay, what about targeted therapy?
This is for tumors that are HER2 positive. This means they have a protein that makes them more aggressive. The drug trastuzumab, or Herceptin, specifically targets that HER2 protein. It's been a game changer for these patients.
And finally, chemotherapy. Who needs that after BCS and radiation?
Chemo is for patients at the highest risk of the cancer spreading. This generally means anyone with node-positive disease, a very large tumor, or a biologically aggressive type of cancer.
Like triple negative.
Exactly. Triple-negative breast cancer is the classic example. Since it has no receptors for us to target, chemotherapy is the only systemic option. It's also used for most HER2 positive tumors because of their aggressive nature.
So the surgery and radiation are the fixed foundation, and the systemic therapy is highly personalized based on the biology.
Precisely. BCS is fixed, the systemic therapy is tailored.
This has been an incredibly detailed look at a protocol that requires so much synchronization. Let's try to synthesize this into the ultimate quick review of the highest yield points.
Let's do it. We need to consolidate the absolutes. First, the key outcome. BCS survival is equal to mastectomy survival. That's from NSABP B06.
Number 2.
BCS always requires radiotherapy. No RT, no BCS, period.
Number 3. The surgical goal.
The adequate margin for invasive cancer is no tumor on ink.
4. The lymph nodes.
Sentinel lymph node biopsy is the standard for clinically node-negative disease.
And 5. The modern technique.
Oncoplastic techniques are the standard now. They allow for larger excisions with better cosmetic outcomes.
And let's hammer home the absolute contraindications one last time. The deal breakers.
Multicentric disease, diffuse malignant microcalcifications, and any inability to give radiotherapy, whether from prior radiation or pregnancy.
And inflammatory breast cancer.
An inflammatory carcinoma is an absolute no. The moment that diagnosis is made, it's a completely different treatment pathway.
It's just amazing how far surgical oncology has come, from maximizing removal to maximizing precision, all while keeping the patient's quality of life front and center.
It's a phenomenal system when it all works together. BCS is the preferred treatment for early breast cancer when all those safety criteria are met. It's a combination of surgery, staging, radiation, and personalized systemic therapy.
And when it's done properly, the outcome is clear. The same survival as mastectomy with a profoundly better patient experience.
That's the bottom line.
So we took a comprehensive look at breast conservation surgery from that initial triple assessment all the way to the landmark trials like NSABP B06 that established its safety and efficacy.
And we really focused on the highly structured nature of it all. The clear margins, the mandatory follow-up. It shows the precision required in modern surgical practice.
We established that the entire success of BCS hinges on that mandatory follow-up radiotherapy. It's really the glue that holds the whole conservation approach together. And this brings up an interesting question for you, the learner, to think about as science moves forward. If in the future we develop highly targeted systemic therapies, maybe advanced immunotherapies, or revolutionary drugs tailored to a tumor's genetic signature, and these therapies become so effective that they eliminate the need for radiation, demonstrating the same local control.
Right.
Would the formal clinical definition of breast conservation surgery then need to be fundamentally rewritten to omit that mandatory third step? And if it is, what would be the new metric for success beyond just getting clear margins?
That's a fascinating thought. A future where surgical conservation relies solely on biological control rather than physical sterilization from radiation. The definition is tied to the evidence, and new evidence might just force us to rewrite that history.
Thank you for joining us for this deep dive. We hope this knowledge serves as a valuable shortcut in your pursuit of clinical excellence. We'll see you next time.